Good afternoon, everybody. I have the pleasure here to introduce our dear professor, Professor Dr. Gamal Mustafa from Cairo University, who will talk about post-surgical patient requirement from antibiotic and analgesic. And after that, the panel. Okay? Dr. Gamal Mustafa, please start.
Thank you very much, Mr. Chairman. I know that the data that I will show to you in this presentation is not new, but it is a good chance to refresh our idea about some important points in antibiotic management for surgical lesions. Because recently we have the new concept in antibiotics. So when resistance occurs, it is better to look to the back. We start to revive in the old generations of antibiotics to avoid resistance, which is a real problem nowadays. The first point is that it's better to say antimicrobials than to say antibiotics, because antibiotics means that the product is an end product from microbacteria or bacteria. But antimicrobial can include also the drugs that we use in everyday practice, which are synthesized in the lab and in the factories. So all antibiotics are antimicrobials, but not antimicrobials are antibiotics. An antibiotic is a substance derived from a microorganism, but an antimicrobial can be synthesized. Stressing nowadays about the role of fluoroquinolones in the medical era, because fluoroquinolones were introduced in the medical field some about 30 years ago, and they reached up to the fourth generation. And with the increase of the with the increase in the generations, the resistance started to show, and the side effects started to be magnified. And according to the new concept of looking back to the earlier generations, the drugs can be used safely. And we all heard about banning of the use of some members of the fourth generation of fluoroquinolones, particularly decatefloxacin, which is its production stopped and its use in the medical field is banned nowadays. We made a study about 10 years ago about the bacteria flora present in the Egyptian hospitals, because we were treating Egyptian infections according to the guidelines that are used abroad. I don't think this is correct. So we started to make swabs from the microorganisms present in the 11 intensive care units, cardiothoracic, surgical, orthopedic, gynecological, and even in the intensive care units of belonging to the medical practice. And we found some important information that may lead us to the use of certain types of antibiotics that are more effective and more cheap in the Egyptian infections than in the infections that are recorded abroad. Brooke in 2005 said that a microbe can move across the globe in 24 hours. In fact, if a new microbe and a new resistance develops in the state, it can appear after 12 hours in Japan, and it comes back again to the United States in the 12 hours later. So before we start, we have to know that surgical infections do not face the surgeon at the first one. It is the job of the general practitioner, and the infections that we face that are not related to surgical operations in the first step. We face infections that do not belong to the operations much more than we face infections that belong to surgery itself. The non-operative infections mostly involve the skin. Number two, and much more common infections related to surgical operations. Surgeons face every day in the skin, I mean. General practitioner, not the surgeon, are the front line. First few examples of the common infections we face in the surgical practice is the boils, that infections in the hair follicles, like this. We have the furuncle, where a sebaceous gland is also included. We have the carbuncle, when the furuncles are grouped together, and they are common in patients with immunocompromised patients, particularly in the diabetics. We have the hidradenitis suppurativa, where scarring during the healing process occurs, and it's common to occur in the axillae and groin area and in the pubic hair, the region of the pubic hair. And sometimes in advanced cases, we meet cases that we need to change the skin of the axilla to treat the condition and to make the life of the patient more comfortable. These are examples. This is an early case, and on the right side is a late case with extensive scarring in the axilla. We also, from skin infections, we have lymphangitis. It's easy to diagnose because it runs in streaks, minute streaks, extending from the site of infection to the lymph nodes, draining lymph nodes. We can get also lymphadenitis. We faced many years ago with the extensively resistant microorganism, the MRSA, and this is a case of cellulitis. It's also easy to diagnose, and it's cellulitis again. This is cellulitis also. We have cellulitis in the chest wall, axilla, and arm. Cellulitis in the lower lid, and erysipelas, which is infection of the very superficial layers of the lymphatics of the skin. It is easy to differentiate from cellulitis by having a very well-cleared edge, a margin. This is an example of cellulitis. Impetigo, where the infections leads to crust formation. We have paronychia, and when the paronychia occurs on the either side, it is a runabout infection. We have ingrown toenail, where infection is common. All these lesions we face every day. We have the diabetic foot, and these are examples of early lesions and late lesions. We get mastitis, where infection occurs in lactating breast. But for the surgeon, the abdomen is a very special place. The surgical site infection it's rare, it's not common. The type of infection we meet as surgeons is not the surgical site infection. The overall infection rate is 0.4%, and when the infection control system is tight, 6% in the intensive care units, and the surgical site only 20%, while the respiratory tract infection is in 56% of cases. Probably the infection is transmitted through the ventilation system. Urinary tract is 4%, and the bacteremia 14%, and others are 15%. Peritonitis is a very special case that faces the surgeon, and when we start thinking of antibiotics, we have a very long list, concentrating more today on the quinolones. When the classification of antibiotics, we found that it was based on the spectrum of activity, effect on bacteria, and the mode of action. And we have two problems in a great march nowadays, the resistance and the side effects. And according to the WHO in 1999, 40% to 91% of antibiotic prescription is inappropriate. And this inappropriate prescription is the first cause for the development of resistance. The antimicrobial resistance also coincides with increased use and the abuse and the misuse of antibiotics. It is important in surgical practice, especially when the operations are major operations, to think of using the empirical antimicrobial therapy, We match the bug with the drug, and we do a culture and don't wait for the result. We start the treatment by empirical antibiotics. There is evidence that not providing empirical antibiotic or antimicrobial therapy active against the subsequently identified pathogen is associated with increase in their mortality. We give the antibiotics for 1 to 7 days. The treatment paradigm nowadays is the correction of the underlying cause by drainage. Just 1 minute. We correct the underlying cause by drainage. Then we give systemic antimicrobial, and this systemic antimicrobial is against the most expected microbe after taking a swab. We don't wait for the result. Don't wait for the culture. Use a life-saving empiric combination. And the standard two empiric combinations is the use of quinolone with metronidazole or second and third generation cephalosporin. And according to the principle of looking back again to avoid resistance, we prefer using the second generation cephalosporins. Ciprofloxacin amrozole infusion cover all microorganisms that cause intra-abdominal infections, especially the most resistant one, like the Pseudomonas and the bacteroids. And we have the magic combination of using second generation cephalosporin with amrozole, and we don't miss using extensive analgesia after major surgery because this is important for patient recovery. Thank you very much.
Thank you, my dear Professor, Dr. Gamal Mustafa, for your presentation. I think there's any question, 1 or 2 questions for that? Antibiotics. Antibiotics in surgery is a very good subject to discuss. Okay. No. Yes? 1 question. Yeah, yes.
For Pseudomonas, you mentioned Pseudomonas. Which the strong antibiotic for Pseudomonas?
For
Usually
Pseudomonas, we have
diabetic patient.
Yes, we have too many antibiotics that you can give. But if you want to feel safe, the resistance increasing with the increase in the generation. So cephalosporins are effective against Pseudomonas, and the earlier generations of cephalosporins are potent than the late generations. So we prefer to use the second and third cephalosporins in an optimal dose, and if always combine them with amrozole. Flagyl, metronidazole.
One short question for Dr. Abdelmati, Dr. Suleiman al-Shakhs. We have 2 minutes only.
I just, several times you have seen patient diabetic with severe cellulitis. What is your regimen to start with? Cellulitis, edema, lymphangitis, ferric, and she is diabetic.
Actually, on my practice, I don't believe very much on doing monotherapy for those cases. Combination antimicrobial therapy is much better, and this is a good combination. But you can use other types of antibiotics also in combinations.
Like what?
For example, using penicillin derivatives, which is very effective. We have an oral penicillin nowadays, which is Ospin. You can give 1 tablet in the morning and 1 tablet in the afternoon, combined with 1 of the cephalosporins by injection therapy.
Dr. Abdelmati, you have one inquiry, very short, please.
هو أنا بس عايز أعلق على موضوع السودوموناس. الحقيقة السيبروفلوكساسين أو السيف جينيريشن كفالسبورنز are not now effective against Pseudomonas because it has a very high resistance. يمكن الوحيد السيف جينيريشن اللي ممكن يأثر عليهم هو السيفتازيديم. إنما it is better for Pseudomonas to use carbapenems, either Tynam or Meronam, or Piperacillin tazobactam as tazocine. This is the ideal treatment of Pseudomonas.
But
Thank you.
carbapenems should be given in a hospital. يعني. It needs a hospitalized patient. But at home, you can use usual and regular antibiotics.
Thank you. Thank you very much. Thank you, Professor Dr. Gamal Mustafa, a dear friend from Cairo University. Thank you very much. Okay. Let us, with pleasure, I call for the next panel, Professor Dr. Ahmed Abdelaziz, Professor Dr. وائل خفاجي, Professor Dr. وليد ثابت, شريف عبد الحليم, Professor جيم خان, Professor سيكا, Professor إلينا.